in terms of ICORC, I mean, we're involved in clinical trials in Ireland in the cancer space, and I suppose this is a point to Graham's presentation, which was really, you know, the move from the HRB to look at PPI seriously and incorporate it into the 5-year strategy is really important. And I think from an ICORC point of view, we'd certainly be very interested, because as someone who's come from 8 years of working in the space of PPI and trying to drive that within Ireland, to a space where I've got Verena and Vittorio sitting beside me from ICORC with people who are actually doing research. I could really bring that learning into the organisation. I think we'd be very willing to be the pilots in that space, because I think there's a lot of learning, as you've said, to do. From the Philip's presentation, I just wanted to talk to you a little bit about quality in health service, and I suppose the point would be, if you have an enhanced clinical research infrastructure in our hospitals in particular, you have a better standard of care. And I suppose that speaks to your quality slide, and you know, research isn't part of that yet. And I think in terms of, you talked about consultants and how hard it is to get them now, you know, if we start to incorporate protected time into our clinical researchers' agendas, so it becomes part of their performance review as well, I think that might actually become attractive to those working in our health service. So those are just the 2 points I want to pick up on, and congratulations again today, Oliver. I think it's great to see Aoife at this table. I think it's really important. I can see lots of partnerships that could happen between the 3 of your organisations within the PPI space, so thank you.
Can I just make an observation? I haven't a clue who you are, and will you just explain just some of the background to the issue so we can all get a greater sense, because the more communication we have, the better it'll be.
I think if you ask people to put their hands up to say who doesn't know me in this room, I don't think you'd find many, so apologies for that. A lot of the people in this room I would have worked with in my last job. I'm now the CEO of ICORC, which is a cancer trials organisation, but previous to that I was the CEO of IPOSI for 8 years, which is the organisation partner with Aoife today. And I suppose I've come from the perspective of representing patients to the state, to the Department of Health, to the HSE, to the IMB, now HPRA, and the Health Research Board, to now working with people who are involved in both clinicians and researchers and translational researchers who are involved in bringing cancer trials to Ireland, and the majority of cancer trials to Ireland. So it's a great space to be in with the background I've come from, because now I want to really get those patient experts at that table as well.
Fantastic, thank you.
Hello, I'll introduce myself first, because I wouldn't be as well known as Evelyn at all. My name is Mags Rogers. I'm from an organisation called the Neurological Alliance of Ireland, which is an umbrella of patient organisations representing people with neurological conditions. It's more of a comment really than a question on Dr. Philip Crowley's presentation, which I really enjoyed. Just in terms of service user involvement, I've had a fairly unique perspective, I suppose, over the last number of years in terms of the Neurological Alliance engagement with 2 of the clinical programmes in the HSE. I think there's over 30 clinical programmes at this stage, and the Neurological Alliance was part of the programme team for 2 of them, still is. And what I would have found, just in terms of Dr. Crowley's comments on service user involvement, there was a huge willingness on the part of the clinical leads, who are consultants, and the programme teams to encourage service user involvement, to have it as part of their models of care. But what we found was there was a how in that conversation, and the how was coming to us as a patient organisation umbrella. And I think there is a huge opportunity still in the clinical programmes to embed that service user involvement and to give the programmes the how in relation to it.
Gentlemen.
Just to come back on the 2 comments, thank you both very much. Eileen, yeah, I mean, I think I obviously agree with you that the more of an academic partnership you see in practice in the clinical space, probably the better care that will result. We haven't been very strong on that. It's largely been based on people's own commitment and willingness to do extra work and do it outside of normal hours, an awful lot of that. So 2 things happening in that space that maybe will improve things. One is the McCraw group, which I ended up serving on, because it was initially I wasn't on it, and I made a strong critique of some of the direction they ended up on it, which is what happens obviously. And anyway, so the McCrowder, one of its findings was that we do need to develop new models of contracting our staff. In this instance, doctors, but it goes for nursing staff as well, and allied health professionals, that protect time, that builds it into the contract. Otherwise, we just can't assume it's always going to keep happening. So maybe that space will open up. The other thing I hope that will be a good driver for the kind of research we'd like to see relevant to service users and patients is the academic partnership that's supposed to be at the heart of hospital groups. So hopefully, that again will strengthen the academic focus of our healthcare system, which needs to be strengthened. Mags, good to see you again. It's interesting, you're obviously, when I talked about a constituency, you have a very well developed constituency. It's a very good example of being able to kind of go back and you have a sounding board and different organisations, different views. The clinical programmes are an obvious space, but all spaces need to take your message on board, and I'll take that back to Anya, who will be very open to it anyway. And the clinical programmes are reorganising at the moment, so there's a point in time where they will kind of, if you like, design the way they're going to work. So it's a good opportunity for that message to come through.
Just to follow up on Mags's question, I think you probably saw one of the slides I put up from the UK organisation Involve, who've been doing this patient involvement for 10 years and are reasonably sophisticated at it. But as I said, they've done a review and they've learned some painful lessons. And one of the things that I think that I highlighted there is that the provision of support needs to be quite specific. Now that's code for resources, okay, in terms of training. If people aren't professionals, it can come down to simple things like travel bursaries and things to go to some of the meetings, the things that are kind of quite possibly taken for granted by academics and clinicians and researchers working in universities, etc. So this provision of support. Now, I'm going to go back to a comment I made earlier about learning to walk before we run. I'm convinced that the provision of sufficient of those resources will only come if we start in small steps and prove its value, so that it actually, if you like, wins the argument for the provision of further resources. But I think, we don't currently provide significant resources in this space, so I'm not surprised that you asked the how question.
Oliver, any? No one fine? Right. Any other? Lovely, sir.
Jerry Cummins is my name here. I'm a rural-based GP, and I'm here as Vice President of the ICGP, Irish College of General Practitioners. I'd just like to compliment the organisers on a wonderful meeting this morning. It's great to see the patient as the focus of things, and this is what we do. In particular, I'd like to compliment Dr. Philip Crowley for his presentation and all the work he's done. From our point of view in the ICGP, it's wonderful to have someone like Philip who is GP trained and still working part-time as a GP, and I think it's really good for us. We have huge problems. I could go on all morning about the problems of access to secondary care and all the rest, but with Philip at the top table, I'm optimistic that things can change. Just as regards patients, our ICGP and our involvement with patients, we interact with a lot of patient groups. That's one aspect of things. There is what's called patient participation groups, and this is a slightly different issue which occurs at practice level. Now we haven't done particularly well in that area of patient participation at practice level. This has been done in the UK with mixed success, but it's something maybe that we could look at in the future. Thank you.
Hi, I'm John Kiernan, Managing Director at Quintiles here in Ireland. One of the things we've heard a lot about over the last number of years is big data. And I think there's a lot of discussion about data and not enough discussion about quality, actionable information. And I would feel that all three of you spoke this morning in one way or another about getting data. Philip talked about metrics. Oliver spoke about real world research, and Graham, I know it's a central theme for you and a lot of what you talk about. Could each of you comment on where Ireland is and where it needs to be in terms of gathering data, analysing that data, and then turning it into actionable information? Thank you.
Can I start? Okay, hi again, John. So we're quite a long way behind. There's a lot of data collected, but not a lot of it connected together and put to use. If I paraphrase your question about not just the quality, but actually linking it, etc. I do think we took a significant step forward finally earlier this year, or was it late last year, with the legislation for the unique identifier, many years after other jurisdictions have had it. So I think that's going to give us a central plank around which to start linking the data together. For me, the key isn't necessarily aggregating lots of new pieces of data, is actually connecting what's already there in the HYPE system in hospitals. There's fabulous data in the GP network. It's probably the best actually set of data in many cases. But also administrative data sets that sit in non-clinical situations, in Department of Social Welfare, in education, etc., to allow us to connect together and make valid judgments about cause and effect on certain things which are missing, quite frankly, in Ireland today. I do sound a warning bell. I'm quite concerned about the data protection regulation in this context. Just as we get our unique identifier and it looks like the roller coaster can start moving, there is the threat of data protection regulation coming from Europe, which could lock down a lot of this. As the infrastructure grows, the rules governing it could tighten it down so badly. And that is where actually the power of patient groups is going to be critical, pushing back on that regulation.
Yeah, and maybe just to add to that, John, I think you know the answer to the question, and it's just a question of whether do or do we. Clearly we are behind. We're very significantly behind. You know, you engage with, we had David Dalton over from Salford, very visionary leader of an acute care institution, and all the data on their performance is freely available on the ward around the hospital. People going in can see it. They can also see it, importantly, and this is something we invariably miss, is the variation in performance between different settings within the same institution. Because we deal an awful lot with aggregate data, and I think if you're going to improve quality, you need to examine variability. So we need to disaggregate the data and compare. Then you get into all the arguments about, are you comparing like with like? You know, our place does this, therefore it's like that, and there's always 1,000 reasons why the data is different and nothing whatsoever to do with the quality of care. And sometimes that's correct, but at the very least you get into a dialogue about what trying to convert, as you say, into information. We had a guy over from, I think he lives in Austin, Texas, Lloyd Provost, who's kind of an international leader in quality data. And I managed to get the leadership team to sit down and listen to him. And he also did sessions with people leading around the hospital groups and the community settings. And really, I suppose the take home from that is that we need to also look at data over time, not just be setting targets and failing, but trying to track improvement over time. And I think that's certainly the direction I'd be pushing in over the next couple of years.
I'll take two more before the break. Lady here, just thank you very much. And at the back as well, and that'll be us, then we'll have our break.
Will I go first? Yeah. My name is Gay Stevens from Trinity College Dublin, and just to follow up on that last conversation about information. So I work at the Centre for Health Informatics, and we're all about information and trying to get a voice at the table. And just to follow up to as well as having the unique identifier legislation, we've also had the appointment of a Chief Information Officer in Ireland for the very first time, and he's busily working away at his job, but we're still way behind. And I think it's incredibly important at this patient event that we start thinking about how we're going to include the patient information, not only the healthcare information from the clinician side. And in order to do that, we definitely need an information architecture, which is being worked on by Peter Connolly in the Health Services Executive. So he's just rolled out some documents about the information architecture that we may need. But one big challenge I think we have, and we really need to address it, is in the education space. We are not getting the funding either in Trinity College or in UCD, who run these programs, or in Limerick, to support the students. In Trinity, we're in our 13th year, so there's lots of graduates out there. They need to be harnessed, but also our programs need to be supported by the HSE. So that whole education space and research space needs some support too.
Thank you. Lady just here. Have we got a microphone for you?
Sorry.
Yeah, lovely. Thank you. Lovely.
I welcome your IMOX Ireland Organisation for Anticonvulsant Syndrome. I welcome the EMA and all that work. Sorry, I got really shy, but I welcome your information on the adverse effects and that. I'd just like to say thank you.
Thank you very much. Any reaction over on my left-hand side?
I suppose I can go back to the earlier comment about provision of support. If I read it right, it's at the back. It was about, you know, the generation of data scientists and broader. Is that in the provision of funding support? Health informaticians. I mean, it's not just in the health space. I suppose, to be frank, there is a lack of. There is a new demand in this space which has greatly exceeded, I suppose, our production on the human capital side, graduates, postgraduates, researchers, etc. I mean, you would get exactly the same conversation taking place in IBM, Hewlett-Packard and Apple at the moment, looking for people who are trained in this broader area. And I guess it is up to our system to catch up. It's a little hard for me. I'll be defensive here. You know, I go back to my 43 million. We were trying to do rather a lot with it in a system. To extend that out to supporting further programs here, I'll be frank, would be an extreme challenge for me under my budget.
Yeah, and just to add, maybe, I welcome your kind of sense of optimism. Maybe I think we have to be optimistic. People criticise me for being optimistic sometimes, but I think if we're not optimistic, then I suppose we've thrown the towel in. But we have a long way to go. I mean, I speak to people working in the front line. They don't have access to a computer in the acute setting. It's absolutely unbelievable in this day and age. Whereas in general practice, it's highly evolved. I think Richard Corbridge's appointment, as you say, as the Chief Information Officer in the HSE is providing a massive amount of energy and new ideas. The unique identifier is long overdue and is now something we need to mobilise into the system. So I am optimistic, but we have a long way to go.
If I can, yeah. I would add that, from the pharmaceutical industry point of view or from our association point of view, I've said before, we want to be at this stage in Ireland advocates for intelligent investment in health. And part of that intelligent investment is going to have to be around the area of data and about research, because that is the type of intelligence, after all, it's a knowledge industry. And we have to advocate, all of us, for the investment in the infrastructure that makes that available. The IT, it sounds boring, but it is true, it has to be done, and the information systems and the information people who will analyse that information. But to build on something that John from Quintal said, once you put the word big in front of something, people get suspicious of it. And so when we talk about big data, people are going to be anxious and suspicious about that. So one of the key things that I think a lot of us have to do together, all of us perhaps, is to build a sense of data being gathered and analysed and researched and so on and so forth, but in a context of trust. Without the trust from the public, the legal thing that Graham was talking about is built out of an issue of trust. And we're going to have to work on a situation where patient information that we want to provide to enable better outcomes is done in a trustful environment, in a way which is secure, but it's all trusted. And I would believe that the main way to get that trust is to have it focused on what exactly it's going to be used for, and that the key purpose being better outcomes for patients. If we can't establish that connection to better outcomes for patients, I would imagine patients groups, patients themselves, the members of the public, will be less likely to support it. If we can establish that direct connection, then we have a chance of building an intelligent infrastructure for investment in health.